So we're going to spend some time, just for the second half of the session, looking at a couple of case studies, and really, apart from that core EDM, where has Ipswich taken Evolve next? So after EDM, what have we got? Well, as we've been trying to say all along, proactive engagement from the users is absolutely vital. So, for example, suggesting areas of improvement. So, as Damien said, yes, we're relatively new into the healthcare market, and the NHS is its own special beast, if you like. But the idea is that the users on the ground have a channel where they can say, actually, do you know what, that works better for us in this setting, or we'd like some things to be changed. So the idea of setting up subgroups like clinical or medical secretaries, pharmacy, the scanning team, all looking at their own little areas and being able to then suggest where those can be improved, and also suggesting new items, as we'll see in a second when we talk about diabetes, being able to create a diabetes solution. The emergency department has looked at it in terms of scanning in the emergency department cards. So for us to have a very engaged clinical group making these suggestions, giving us really positive and at times constructive negative feedback has been absolutely vital. And we feel, and I hope and I trust Ipswich feel the same, is that with Evolve they have got a very strong tool set and a toolkit to really start driving efficiencies in the organisation. So with the workflow, with processes, with electronic forms, with the ability to integrate into other systems, they're really starting to see the benefit. And it's the area where the trust can really grow the solution as their needs grow and as they change going forward. So I'll hand back over to Damien, and Damien's just going to talk us through some of the work that has been done with the diabetes team and taking the core Evolve system and really modifying and taking it into areas that we potentially are new for the solution.
Thanks, Colin. I think it's fair to say that Ipswich is a nationally recognised diabetes centre, and certainly one of the things that attracted me to go and work there. However, since I arrived in 2005, we've really struggled with a database system. We had one which was built in-house at the time, but by the time I got there, or soon after, it just sort of died. It was impossible to maintain, and ever since then we've really been looking for a system to take over. It's not very good for patient care. It's not very good for our needs not to have a database for a disease like diabetes. And more recently, we've had criticism from the Primary Care Trust about not being able to provide performance data to them. And of course, in the current healthcare market, that's incredibly important. We've spent some time, in fact many years, looking at off-the-shelf options, but there's always been problems with all of those that we've looked at, and nothing's really met our needs. So it's actually been quite refreshing to actually be able to consider new options recently. Of course, we've got quite a lot of requirements. As I said, it really would be very useful to be able to integrate it into what we've got currently. We all get fed up with having to log into a new system each time. If you've got a database that's already incorporated into a system that you're using for most of your patients, and you can just go straight in and pull out the database whilst you're in the same system, it does save an awful lot of time. We, of course, need to be able to capture information from clinics, both the clinical but also the administrative data. As well as just being able to capture the data, what we've not been able to do is actually report on it, actually analyse it, both in terms of giving data back to the trust, to the Primary Care Trust, but also in-house for research and just improving patient care, doing audits and just moving forward in providing a better service. So it's been a deficiency for some time. Very pertinent now is rapid communication with primary care. We're now being fined, or we will be fined from the beginning of April if we don't get out letters within 72 hours to GPs. By having a database system, we can improve the speed of communication because it's all going to be done on a form-based system, and that can just be literally emailed to the GPs very quickly, as in our discharge summary, as Colin pertained to earlier. And of course, as you've seen from some of the stuff Colin showed you, the whole Evolve system is very customizable. We can actually go in and we can make changes as we go along. We can move forward in the future when new ideas crop up that we want to do. So how have we approached this? Well, it's taken a bit of time. We've looked at what we've got currently in a paper form. We've gone on to I've gone on with one of our IT technologists to create a prototype in electronic format. And I think it's to be fair that we've fed this back to my other clinicians, and I think they're very happy with it and want to move forward. I think this is the way forward to actually get what we've been looking for some time. We've got a project lead, which is very helpful. You certainly need someone who can access all the form development that we can't do as clinicians and take that forward. And we're hopefully going to be making some progress over the next few months to actually introduce a system we can actually get up and running. And as I said, hopefully it's going to be very flexible to what we need in the future, because almost certainly the healthcare market is going to be changed within diabetes. A lot of type 2 is moving out into primary care, and we want to hopefully be able to communicate with our GP colleagues, send information back and forwards, and actually ultimately improve the care for patients. So I'm going to hand back to Colin now, who's going to tell you some of the other projects that have been going on in Ipswich, which he's got a bit more details of.
Okay, thanks, Damien. So we want to look at the emergency department and a couple of things that we've been doing with them. And the first is the emergency department attendee summaries. And really, so the issue is, as of the 1st of April, so this Friday, there's a deadline very similar to the one that we had in April 2010. In April 2010, it was for an inpatient spell, get back to the GP upon discharge within 24 hours. Well, now that's been extended to also cover the emergency department. In Ipswich, there are about 150 patients a day in the emergency department, so getting back to the GPs, again, an issue where good control of information and timely sharing of information and sending of summaries is going to be key. The College of Emergency Medicine in 2009 showed that about 58% of all notifications were delivered by letter, so 58%. Trying to do that by letter is just not going to be achievable, getting those back within a 24-hour period. And so the approach that we have taken is, we talked already about the discharge summary component that we built in at the request of Ipswich, and so it's been an extension of that component for the emergency department, so very much an ED-focused discharge form. And so at the end of at the point of discharge from the emergency department, the attendance summary is then automatically sent to the GP, again via the most appropriate channel for that GP. So some GPs will still want it in letter form, some GPs in email, some GPs can accept a direct fed item via the interoperability toolkit. And we've worked very closely and very directly with the clinical lead and for the clinicians really to build upon this. And obviously enough, I can appear in the emergency department multiple times in a short space of time, and so the ability to have multiple concurrent admissions is also where it's slightly different from the standard discharge summary functionality. And so the outcomes that we've had, well, this is currently being tested for final release, and in fact, I've just been reliably informed that this has actually just about gone live in Ipswich, so we're right on time for the April the 1st deadline. And we see this as being the starting point for the creation of a fully electronic emergency department card, so not just at the point of discharge, but as they progress through the emergency department pathway, the entry of all information online, so that we're actually then again starting to target pieces of paper in the organisation, that we can start moving away from paper and start moving towards a fully electronic world where we're then better able to share, to store, to control that information. In terms of usability, the clinicians are really loving this, because what we're seeing is that, yeah, they've got the process down for actually completing this form into about a 3-minute period, so they've very much switched onto this idea of fully electronic working. And again, it's all going out to the GP bang on time. Taking a step back from the fully electronic way of working then is, well, what about the paper within the emergency department and all of those emergency department cards? So here's a typical emergency department card. And so every time I attend as a patient within the emergency department, a new ED card is created for me. And when I leave the emergency department, that card will be held for a short time within the department, and then it will be moved to an on-site storage location. So in the case of Ipswich, they had a massive room full of these emergency department cards. And so they had hundreds of thousands of them, obviously taking up a large amount of space. And whilst this idea of scanning these legacy emergency department cards was on the, on the cards, but on the approach for Ipswich to tackle them at some point, it was felt originally that this could actually be a lot of effort and a lot of work, because the cards themselves are quite small, so therefore they had a large number of them, and so the indexing, the preparation for scanning at the start was a relatively daunting prospect. And I guess it's one area where a close working relationship between Ipswich and between Kainos has really been key. One of our scanning experts happened to notice the room, had a look in the room, and then we very quickly started to look and say, well, can we actually make this better? Can we look at clever ideas to very quickly prep those items and to get them into Evolve? And so the approach that we've taken is that we built an initial prototype in a couple of days using Evolve's underlying scan solution. And at the point of scanning, then the preparation stage is only very, very simple. It simply involves the guillotining of the booklet, getting it ready for scanning. When we feed that guillotined discharge card into the system, Evolve's underlying scanning solution has sophisticated forms recognition built into it. And so the system has been trained to recognize that that is an emergency department card. As it's an emergency department card, it then knows where to look for the hospital number, for the visit date, and it extracts and OCRs those pieces of information automatically. And then that file, that card, is automatically filed against the right patient with the right visit date automatically attached. So essentially, there's zero prep here. We're not keying in any information to get it to go into the right place. The system knows it's an ED card, it knows the hospital number, it knows the visit date. It's all automatically filed. So you can simply guillotine them, stack them into big stacks and large batches, and just keep feeding those scanners. No separator pages or anything like that required, and the scanning system just churns its way through them. And so it's been a pleasant surprise for Ipswich and for ourselves in terms of how easy it has been to really leverage the quite powerful underlying functionality within the Evolve stack to really start looking at where we can actually bring real benefit to key areas. And it's really about understanding the technology and how we can then apply that within the actual health context. So the outcome has been, the effort, as I've said, to fully implement this is minimal, because actually there's, following on from that initial proof of concept, we're going to be carrying out further trials just on older forms to see how well they will fare. So maybe the quality of their actual printing is worse. Maybe it's going to be more difficult to extract the hospital number or the visit number. And that's where we're actually looking at. But certainly the initial feedback and all the initial signs are very good, that we can get a very, very quick win here, clearing out space, better managing that information as well. And it's what electronic document management is really all about.